All right. Welcome to Dental Anatomy Review 6. Um, Remember, these lectures are also available at dboardexams.com. Okay. So we're going to review some of the clinical considerations. Okay. So maxillary first premolars, the mesial view, as we mentioned earlier. So we mentioned that the maxillary first premolars have a crown concavity that extends to the root concavity, okay, due to the mesial marginal groove. Okay, so when you're doing the clinical significance of these is that when you are performing a class 2 amalgam restoration, it can be very difficult to adapt a matrix band on the mesial surface of the maxillary first premolar. Okay, this is because of the mesial concavity. All right, and this may contribute to an overhang. An overhang is a trap for food, okay, which further causes periodontal disease and also decay. So you have to keep that in mind. You have to keep the anatomy of the tooth in mind when you're doing the restoration. The maxillary first molar, the distal view, we also mentioned that the this tooth has a cervical concavity which is present on the distal surface of the crown. Okay, so maxillary first premolar has a mesial crown concavity. The maxillary first molar has a distal crown concavity. Okay, and also it may be very difficult, okay, to obtain close adaptation of the matrix band also in this situation. All right, therefore you can create an overhang in this area too. uh, Maxillary lateral incisor, I think I mentioned this before. So the tooth has the most variation of any other tooth in the mouth, except of course for third molars. So this tooth has a gingival, a lingogingival groove or a palatal-gingival groove, which is the anatomical feature of the maxillary incisor that is most likely to complicate root planning. Okay, and the groove is also referred to palatal-gingival groove. Some people call it a distal lingual groove. And so more clinical considerations. So the caries, okay, caries is more likely to occur in the lingo of the maxillary molar than on the distal. I'm sorry, than on the buccal. So the lingo, that's because of of the the distal lingual groove. Okay, remember there's a distal lingual groove right next to the oblique ridge. So caries is more likely to occur on the buccal of the mandibular molar than on the lingual, and that's because the buccal of the mandibular molar, there's on the first molar there is a lingual a buccal pit. Okay, the transverse ridge of the mandibular first premolar often requires the placement of a separate MO and DO restoration because it's a very prominent transverse ridge. Okay, so you only prepare like the mesial and distal pits, okay, separately, and the pulp horns most likely to be exposed accidentally in the preparation of a class 2 cavity is in the maxillary first molar, uh, the mesiobuccal and the mesiolingual. Those are more likely to be accidentally exposed when you're doing a class 2 preparation. That's because when you're doing a class 2 preparation, you have to have that reverse S curve, right? So if you don't pay attention to where the popcorn is, then you may actually uh, injure the popcorns. The So, clinical consideration: the premolar that is most likely to be to pose the greatest problem in root canal therapy, okay, or surgery is the maxillary first premolar, and the root apex can be forced into the maxillary sinus, okay. That's the maxillary sinus is also called the hyomus antrum or maxillary antrum. And then during a surgical procedure would be that of maxillary premolar. So you can do a maxillary molar root apex procedure, but then there's a risk of pushing the root into the maxillary sinus. Abnormal swallowing may contribute to the formation of an anterior open bite. Keep that in mind. Abnormal swallowing, mouth breathing. Also, somebody who doesn't like to keep their teeth, their mouth closed, is going to have an anterior open bite. And during non-masticatory swallowing, the teeth contact in intercuspal position. That's a very important question. Okay. The premolars. Okay. So the premolar that is most likely to pose the greatest problem in root canal therapy is the maxillary first premolar. Let me see. We just read through this one. Non-masticatory swallowing of teeth contact the cuspal, and the abnormal swallowing may contribute to formation of the anterior open bite. Already did this one, and the subluxation. Let's talk about subluxation. So the subluxation of the conda is the when the conda is locked anterior to the crest of the articular eminence, and this is contributed. This is attributed to the spasm of the lateral pterygoid muscle on the same side. Okay, lateral pterygoid muscle spasm on the same side is going to cause a subluxation. In anesthesia of the mandibular arch, local anesthesia is most likely to be effective in the incisor area. And the other one is also the self-cleansing quality of the dentition in normal alignment can be adversely affected by too great a contour of the cervical enamel ridge. That's another key. So the contour of the teeth allows self-cleansing. Okay, if you do over contour, under contouring, then that self-cleansing quality is diminished. Okay. Abfractions. So abfractions are cervical defects that result from the occlusal forces on the inclines of the occlusal surfaces. Okay. So you can see there it's showing premolars which are in occlusion, and you can see in the zoomed in area you can see some of the microfractures. Okay, those are called abfractions. Okay. So abfraction, scooped out, like enamel dentin cervical lesions. Okay. All right, surrounding structures. So the principal fibers of the periodontal ligament are collagenous in nature, as you already know. The oblique fibers of the periodontal ligament are the most resistant to forces along the long axis of the tooth. Okay, so what is the most resistant periodontal ligaments along the long axis of the tooth? Are the oblique fibers. The oblique fibers of the periodontal ligament belong to the general group of the alveolar dental fibers. The oblique fibers are the most likely to be found, okay? They are most likely to be found in the middle third of the root. And so the periodontal ligaments that attach to bone are the apical fibers, oblique fibers, horizontal, and the alveolar crest fibers. They all attach to bone. Okay, so the interceptor fibers do not attach to bone. Transceptor fibers are not periodontal ligament fibers. Okay, remember that, because periodontal ligament has to attach to bone. So if you are not attaching to bone, you are not a periodontal ligament. Okay, the the tissues immediately adjacent to the periodontal ligament are cementum and alveolar bone. The horizontal fibers of the periodontal ligament are situated between the alveolar crest fibers and the oblique fibers. In a normal health mouth, the shortest interdental papilla is located, okay? In a normal health mouth, the shortest interdental papilla is located between mandibular second premolar and mandibular first molar. Mandibular second premolar and mandibular first molar. That's where the shortest interdental papilla is. The bone surrounding the root and providing attachment of the principal fibers of the periodontal ligament is called the alveolar bone proper. Alveolar bone proper, where the principal fibers attach. Okay. More clinical considerations of the surrounding structures of the tooth. So in a healthy state, the height of the interproximal alveolar crest is related to the position of the cemento-enamel lines of adjacent teeth. Okay, so the CEJ, okay, the CEJ, that's why usually the crest of the alveolar bone is in a healthy individual. The free gingiva may be described as forming the wall of the gingival sulcus. And the free gingiva extends from the free gingival groove to the gingival crest. The gingival groove, the gingival and the alveolar mucosa, they differ in that attached gingiva is light pink and firmly bound down, while alveolar mucosa is red and freely movable. You have to keep that in mind, okay? The alveolar process is thinnest at the labia of the mandibular central incisor, and so which is the reason. So the alveolar process is the thinnest at the labia of the mandibular central incisor, which is the reason you can do infiltrations. I usually don't do any blocks if I'm extracting teeth which are anterior to the mental foramen. I just do infiltrations. Okay. That's the end of this review. Make sure you go through the 7 review lectures before you look at this one, because this is a quick review. Okay. All right. Good luck.